Tell me when.
You're live.
Well, hello. I'm live. Welcome to Salt Lake City. You guys can't see me here, but I'm in Salt Lake City today. Great day to do another case. I'm well fed. I had Jersey Mike's for lunch. I'm feeling pretty good. Anyways, we got a great case because it's going to be a retreatment. And I think retreatments are one of the salient things that the GentleWave does for us. It really helps us do a better job. And, you know, I've been doing this job since 2005, and on occasions, you know, even good endo, what we perceive as good endo doesn't work, and we want to know why. And today's going to be one of those cases that we're going to talk about. So that's something to look forward to along the way. Now, so this is going to be tooth number 19. This case was, so it's a retreatment. It was treated by an endodontist several years ago. And when you look at it, there's not much to be critical about it. It's right where you would think it should be. It's kind of one of those older rotary style cases. And we have a lesion developing on the mesial root. And symptomatic, so the patient did come in pain, which is the point of the appointment. And when you look at it on the three-dimensional image, you can perceive the lesion pops right out at you. Whereas on the 2D it's a little bit blurry. And when you go through just really quickly as we're looking through the anatomy, one of the things I like to do is just look at the cross-sectional anatomy. And the reason is when I think GentleWave, I think, okay, well, what's going on in the spaces I can't see on a 2D image? So that isthmus space. And that's kind of the Achilles heel of this case. When you look at it, you can see that it's clearly two canals. But look how broad and ribbon-shaped that mesial root is. And if, as we kind of flow through this here, let's take a look. You know, I'm hoping that's the case. You see the lesion. But what I'm hoping to find before I begin is some isthmus anatomy. So let's line this puppy up here. And then we'll just appreciate how broad they spread apart. All right, so let's begin. Now this this crown was pre-existing the first treatment, so you can see that we're going to re-access an access. You can identify the composite filling, a little different color. Let's get this into focus here. Great. All right. So the burr choice, like I said, there's a lot to pick from. I'm using the diamond. It's just an endo-axis burr. And let's just get through this composite. You know, one of the things when we go through it, especially going through a crown a second time, I'm going to be paying attention to the bond of that crown, for one thing. The other thing is I'm going to be looking at that pulpal floor really closely because I want to know what's going on. Is there recontamination going on, for instance, some sort of coronal leakage? Is there kind of some issues coming into the root canal itself, meaning do I find corrosion products? Is it odorific? You know, what are some of those attributes? And in this one, ironically, it was fairly clean when I got in there. It didn't have an odor to it. Picking along the mesial buccal and mesiolingual canals here, and then the distal. So just looking at it, bright orange gutta percha. So, you know, what really is the cause of the failure? Like, again, I had my bias. I'm hoping that it was isthmus, but looking along that mesiobuccal, mesiolingual pulpal floor anatomy, nothing's jumping out at me. I'm not seeing like that thin line with crud in between. So that's something that I'm paying attention to. The other thing I'm noticing as I'm going in, this is just a retreatment burr, is it's very soft as I go in. It's just kind of, you know, it's sometimes you get into these things and it's like picking concrete. This one was soft. So I just was, as I was picking at it, I just kept going with it. I'm not trying to overly enlarge this right now. I'm just trying to get the bulk gutta percha out. And then as I get down kind of into that middle part of the gutta percha, I'm just choosing a smaller retreatment file and seeing where it goes and seeing what that density is like. Now you can take a look in there. I'm making my way down. You know, one of the problems with retreatments that we all have is as I start putting pressure on that, I'm just smearing the gutta percha and or sealer deeper into any sort of aberrant anatomy inside that canal, inside that root system. So I favor then chloroform, and that's what I'm doing right now. And one of the nice things, well, difficult things with chloroform is it doesn't have a really good surfactant property, so it's hard to get it down on top of the gutta percha, and so I always agitate the chloroform and then just keep sort of dripping it in as I'm agitating with my needle. So I'm just kind of poking it. This is a maxi probe, so it's, you know, got a round tip on it, and I'm just kind of trying to pick at the gutta percha until it bites. And then once it starts biting, you'll find that this gutta percha really gets soft and soupy, and that's what's going to happen here. And it's just a technique, a protocol that I like to do. It keeps you from transporting, and again, my mind is I'm making way for the GentleWave, and my mind is I don't want to smear or push the contents of the dental materials deeper into spaces inside that canal. So once I get that kind of softened up, I'll just go back. This is my 1506, and you know it's not terribly stiff, and I'm just trying to work it in the C-form in as I'm working in through the gutta percha. So it's all I'm doing right now. I know it's terribly fascinating to pick a gutta percha and watch it, but that's what we're doing. Now the other thing is I don't want to go long, so I don't want to push anything out. I got to be careful of that. And so the softer I make this, the safer it is in an extrusion setting. And I don't want to necessarily enlarge it physically. I just want to clean it. And so that's what I'm going to be relying on some fluid dynamics for. I'm finding that the mesials are easier to get through than the distal. You can even see the patient's head as I'm starting to put a little bit of pressure on it. Yeah, there we go. Let's get this in focus. Still really soupy. Once I get, you know, the mass of it out, and I'll do this at different times, but I'm going to keep working C-form until I get roughly to the end. And then what I use is isopropyl alcohol just to kind of clean up any of the gutta percha and ball it up, and then try to get that out. So we're going to pick through this a little bit more. So you paused it, Mike? What he did is he just moved over the time clock so you can see the time clock going. We're 9 minutes into this case. And now what I've done is I've switched over to isopropyl alcohol. And I'm going to try to ball it up and then pass an instrument through it and see what else comes out of there. It's looking pretty clean. Again, look at that mesial isthmus, not much present. So I'm getting a little worried. There's a little bit more gutta percha here. That there really is an isthmus present, and I'm not dealing with some sort of periradicular infection, extraradicular infection, I should say. All right, so picking through here. Now, the 3D shaper, I really like this because, like that, you'll find extra gutta percha in there. Anything that's got eccentric motion is really useful at this stage of a retreatment. At least I find that to be the case. And you're seeing that even though you could see it wasn't like you perceived a lot of gutta percha, I'm still pulling out a bunch of gutta percha in here. And the idea with doing this under solvent such as C-form, I want those walls clean because I want to expose it to the GentleWave fluid dynamic. So we're picking and working, and you know what? There's going to be a decision tree here in a minute. Once I get this all out, I'm going to take a working length X-ray and kind of perceive where things are at. Especially like, did I go long? Alrighty. We go tell Brandy. Okay, so kind of gonna pass I'm passing a 30 in right now. And still finding remnant gutta percha. Now I've switched to hypochlorite, and kind of my logic here is I want to see if there's any tissue in there, and if I can actually see something at this point, just to see if anything effervesces. And now that I believe I got hopefully all of it out, I'm going to take my cones and match it to what I measured on my cone beam. And I didn't obviously use an apex locator in this situation because I haven't really established patency or things of that nature. Because it's already open and enlarged, I'm relying upon my cone beam. And that's what I'm doing. So what I'm using is calibrated gutta percha cones, and then I'm fitting them to my length that I measured. So you can see these are pretty large. Right now the mesial buccal was a 30, the distal was a 35. You can see they're 2 to 1 on the mesial. The 35 looks like it went out a little bit. But again, I was pretty conservative in how I instrumented and removed that gutta percha. So my hopes are that I haven't really damaged that supporting tissue, and it's still a great candidate for the GentleWave. And so we're gonna go pull these things out. I'm gonna look how that 35, if you paid attention as it pulled out, it crinkled a little bit. So I'm gonna trim that. You know, I have a choice when that happens. I trim it to the crinkle, or I go up to a larger size gutta percha. And in these cases, I actually trimmed my cones. So now what I'm going to do is just look and see without any liquid in the canals, and there you go. Not all the gutta percha is out. Enough to get a 35 cone past it, but kind of up there in anismus space, I'm seeing gutta percha. It's in the distal, which has the non-lesion on it, but still really important for me to get this thing as clean as I can. So first thing I did is I just took that 3D shaper back in there, and I'm just picking at that wall, trying to see if I can just flick it out mechanically. Now if I can't, which I didn't, now I'm gonna go back to that C-form, and I'm gonna really bend that needle in such a way where I can just pick, and try to get that same technique where I'm dripping C-form and I'm poking at it and I'm trying to soften it so I can strip it off the wall. And you know, if you didn't do this technique and you just went all mechanical through it, you're obviously enlarging things, but you're also making that denser, more dense and packed tighter up into that little aberrant space that I'm working in. Now you can see, if you look, you'll start seeing that pink cloud because I'm just getting that to soften and strip off, dissolve off that wall. So let's see how I do. Just keep it flowing. And I'll go back to alcohol at this stage too to help ball it up, and then if I need to go back to a rotary, I can. But I'm going to try to get this thing off. So I'm 17 minutes into the case, which is pretty common at this point through retreatment. Fortunately, I'm not removing posts. We all know what that goes like. All right. So now I'm hitting it with some more alcohol, trying to get this thing cleaned or remove all the dental material. All right. Okay, well, it looks like we're gonna get ready to go here. So the next step for me, once I feel like I've done my job and removed and debrided everything inside there to the best of my ability, now I'm thinking commit to the GentleWave. And so what I'm doing on this crown is I'm just taking alcohol on a gauze and I'm just scrubbing it clean. I'm scrubbing the rubber dam. I've used a lot of chemicals up to this point. We used isopropyl, we used C-form, we used hypochlorite, and I'm also trying to remove any pellicle that may be on the tooth structure. I'm not afraid to dry the inside, outside, and down and around that clamp, and the more the merrier. Like I said, I clean it with isopropyl, so it's going to evaporate, but I'll blow it dry. And now I'm just moving over my curing light, and now I just start with the sound seal. And a lot of different ways of doing it, and you've seen it done even by me at different times, but what I find myself doing is the more the merrier, and I'm just coating. I start down at the CEGA around the crown. I'm going to flow it all around the tooth. I want a nice wide platform. It just helps me for patient movement, helps me for just maintaining my seal as real life happens. We've showed cases in the past. We've showed cases in the past where we've had people moving or whatever, and that can be an issue. So this has been a great patient so far, just still as can be. Use the matrix to create the adaptation for the sound, the cap, and the procedural instrument to come on. So let's just give this a good cure. You can't cure it too much. It is conforming resin, and so it does sweat a little bit, and if it's a little bit sticky to your gloves, you haven't cured it long enough. So a lot of times I'm putting my glove and touching it physically like that and seeing if it sticks, and if it does, then I'm going to cure it a little while longer. All right, so my breadcrumb, which was a sponge, let's pop that out, take a look at it. And as you look inside there, you know, it's a smaller pilot hole than what my access was from the original filling. And I'm a believer in removing that original access filling because I want a new bonded wall when all's said and done. So I'm just going to take a slow speed. You can use any type of burr at this point. I'm choosing to use another round burr on a slow speed. It's technically a Muntz burr, and all I'm doing is I don't want to really re-access the walls of it, but I want to make sure there's no sound seal flashing or there's nothing going on. Now, right there on the mesial, if you pay attention to it, there's a little bubble at the cable surface margin, and I'm going to take it out. You know, you could leave it in actually because it's still sealed beyond that, but you can see I'm just going to add a little bit of conforming resin, some sound seal there, and just smooth it out. And the nice thing is you just have to recure it. It's super easy to sort of patch any sort of deficiency or void that may happen. 23 minutes has gone by. My assistant's nice, pretty thumb.
Sean Robertson asked, is your platform ever too thin?
Platforms can be too thin. The question was from Sean Robertson, can it be too thin? And the answer is yes. And I don't want it thin. I want it as thick as I can. And if you're meaning height, I don't really mind the height as long as I can create a union to that cap. I don't mind that. Or if I take this depth gauge and go around it, as long as I have a smooth surface, that's fine. I'm not worried about having several millimeters height above a cusp tip or something like that. I'm more worried about the girth or the width of it. Now, what I'm doing right here is I've selected the cap that matches the depth gauge. And what I did is I just looked through the mouse hole with it. The idea behind me doing that is just to make sure that I have a nice exhaust pathway. So if you go back and pause, you can look through that hole. And the idea there is I just want to make sure that I got it fully seated. Now, my patient's does have limited opening, and as I'm positioning this, you'll see the head of this procedural instrument kind of lean up against that rubber dam, and I'm kind of just jockeying it down into place. And what I'm doing is I'm using the mirror handle to kind of help me push it down there where I'm not pushing into the back of the mouth, but I can get it down the long axis of the tooth. And from there, I can get a really nice seal. And so that's what I'm doing and why I'm doing that. It's like I'm using chopsticks there with my mirror. And I really like to look at the exhaust here. And let's see if I can get it in focus. You can see the exhaust tube. I'm trying to show what's coming out of the tube. But what I'm really looking at, we all look at different things on the screen, but what I'm really looking at is that cap. And I'm watching whatever comes out. And at times, there can be, you can see farm animals come through there, kidding. But you can see purulence, you can see, maybe I can see some sealer come out that popped off a wall, or gutta percha rather, that popped off a wall. You'll see that kind of flutter up through in these retreatment cases. Or in vital cases, you'll see tissue or heme, things like that. Now, there's an explainer video going on that SonEndo is playing that just kind of explains this mechanism. And in some of my videos, we talk about that a lot. But the idea is this procedural instrument is delivering this degassed fluid and putting it into the chamber of the tooth. And the way that the mechanics work is it creates a cavitation cloud, and it's just from fluid dynamics, and it's shear force. And so this animation is depicting how that works, where fast-moving current hits a sound bar in sort of the static fluid environment, and that shear force creates a cavitation cloud. Now that cavitation isn't going down the root, it's staying right there in the chamber, but what it's doing is it's collapsing upon itself. And that's why you get that depiction on that image of this echo, this sort of sound, this multi-spectrum sound wave that then transfers through the fluid that's in the tooth. And that's part of this energy that is disinfecting at this point. I mean, we still have chemistry going on. So the fluid dynamics in this chemical environment accelerates the chemistry, just like any sort of agitation would with chemistry. It's a catalyst, you should say. But then I also have physical force happening with the sound wave that's going on. So we have a lot of different things happening with this technology concurrently, all at the same time. And because it's how it gets exhausted through the procedural instrument, the net effect is this negative environment. And we use that negative environment to try to keep things safe. There's a lot of talking on instrumentation lengths with the procedure, because there's talking about maybe keeping it a little bit shorter than you would from your defined terminus that you define. And you go back a little bit of a millimeter. But a lot of times in retreatments, this gets to be a great topic, because where are you going to define it? You're going to define it where the last practitioner was. And then you want to make sure you can employ the GentleWave, which is what we did here. Now, as you watch what's coming out, I'm just looking for activity. And when you go through this cycle, it's predefined. So it starts with sodium hypochlorite. It runs at 3%. Then you're going to go into EDTA, a rinse, then into EDTA. But as you watch it, you'll see in these retreatment cases, like I said, you'll see farm animals, or meaning your dental materials coming out at times if you've left them in. But at some point you may see heme come through, and that may be defined as you've reached to the end. It may be defined that you've opened up some other anatomy. And that's something that I think as a doctor we got to be really aware of it and make that decision ourselves of what we're observing, and stay really committed to the procedure. Also stay really committed to the patient. If you're pushing too hard, sometimes there's a tendency, especially in a case like this where you're trying to line things up just right, that you're pushing the patient's chin down. So don't do that. You'll find you don't have to push very hard. It's just we're heavy-handed as dentists at times, so don't do that. You realize, I don't need to do that. I like using the mirror handle to keep that position, because it doesn't put a lot of pressure at that point. It also keeps the rubber dam off the head of the procedural instrument, so you can just observe if there's any fluid coming around or pooling around that your assistant can suction. What my assistant's doing right now actually is her notes for the case. So I use this time to also document the procedure and report what's going on. And she'll come back and check her suction, or I'll ask her to come over and make a gesture for her to come over suction if I want, or the patient needs suction under the rubber dam. But for the most part, most of the time, it's just smooth sailing, and unless I'm looking around the room and I move my hand, it's quiet and dry. And then you can just sort of go off to your happy place or talk to your patient or tell funny jokes. I think the GentleWave tries to make us funny because we don't know what to say during this time as endodontists. We just gesture and we're always doing, and now we're just like waiting and watching. And so at the top of the screen, like I said, you can watch what's coming through the tubing. If that's interesting to you, there it goes. You'll start seeing now I'm actually perceiving little poofs of heme, and so I know I'm into that sort of apical third area or isthmus area. Again, I'm banking on this root canal being different than the previous root canal. I mean, it's not, I don't want to do the same root canal twice. It failed. It had a lesion develop post-treatment. And what I gathered from the patient on this case is it was actually a hyperemic vital case to begin with. So this is something that developed along the way over the time course of that previous root canal treatment. So we got to find something here, and that's something that can be found. We're hoping the GentleWave will discover it, because it's not about making a tunnel to the end, to the terminus in this case, or we do surgery. I mean, those are our options. So we're 31 minutes into it, nearing the end. So fun. All right, Lindsay's coming back. The people ask how they just develop the protocols to the time of these things, and when just kind of in some discussions that I've had with them, you know, they do SEM studies on all these teeth that they test in the lab, and from that they've developed timing protocols. And so roughly for the retreatment, it's the same as the extended cycle. If you're familiar with how the console works, you do have a case selection that you'll do based upon the type of case that you have, if it's vital or if it's necrotic. And you have a choice to sort of extend the cycle, and roughly the retreatment's just an extended cycle. It does sync with TDO, so as you make that decision tree, that can be entered into your notes, which is quite useful for follow-up, recall, and just being accurate with your information. It's very good. So getting a little bit of pooling now. Frankly, that can be for a lot of reasons, but for me it's actually just position. Sometimes when you see that, it could be that, especially in a case like this where we're re-accessing the same crown, and that crown pre-existed the previous root canal, that you could be washing out some of the seal of the crown, and which is a good thing, because it should get replaced in that situation. But this is just me looking around the room and not just sort of having things lined up in that kind of tight environment. So I put my mirror handle back on and just re-corrected myself. And one of the things, if it is that the crown's washing out, one of the things that I found is you'll find that it is towards the end of the cycle, but you'll see, when you look in, you'll see heme, because sometimes that can get down and around the crown margins and get down into like the gingiva. And if that's the case, you'll notice it when you pull it off and inspect. And so it's always appropriate to stop and look if you have to, and determine what's going on. Now you can see that we're looking inside. There's not a lot of heme until I actually put hypertonic saline in and kind of get down to the terminus, and I can say, okay, yeah, we've cleaned the end. So we have patency at some level going on, but not necessarily active bleeding, and the crown margins internally are well set. So I like all that. So it means, okay, we don't have to replace this crown, and I've done my job and didn't over-instrument, and at least I believe at this point the GentleWave has done its job, because I've developed patency by visually relating that to some of the heme that's coming up, just the minimal amount, which is kind of, in retreatment cases, it's usually just minimal like this. And I'm going back to my cones that I did, and I'm going to see if anything enlarged, because like I said, if we had, when I did my first working length, I still had gutta percha. I could put a 35 cone in that distal, but I still had gutta percha on the walls. And now that I've ran the GentleWave, if I wasn't 100% perfect in removal of that material, maybe something falls down and my cones don't go to length at this point. Or maybe I dislodged something with the GentleWave and it's there. Or maybe actually dissolved out something and it made it a half step larger from like a 30 to a 35. And so I've learned just at this point, it's kill two birds with one stone. I'm going to go check my length again. And if I have a little bit of heme, I'm going to do that under the hypertonic saline and just let that clot naturally form down there. And I take another working length. Now, I use my trim cones from the first go around in the second go around. And that's kind of nice too, because I can either go up a size or trim again if I want. And in this case, I'm going to trim just a little bit more. And from a 2D x-ray, it does not look like much is different other than I've retreated the case. So you can scratch your head. Even when I was looking in that anatomy, I didn't see much along the pulpal floor because it had dentin, like true dentin between the orifices. And so the idea is well, what did we really do? Did we really clean up an isthmus? Or was it just biofilm along the main canal? And that was the reason for the failure. And I have a hard time believing that when I know it was a reputable endodontist that did the case, and I know the case looked really good, and I get into the case and it's not corroded and it doesn't stink. And so, man, what's really the causative agent? Like, where is it? What caused this failure? And I think we all struggle with that as endodontists. We want to know. I want to know all the time where the etiology is, and can we discover, and can we do a better job? And so, fortunately, we don't have much but what we've seen observed along the case. And you'll see me, I'm drying it, just making sure that we don't have any active supporting tissues bleeding into the case so we can get a good seal. And now I'm going to obturate and see if I can answer my questions. And what I like to do is, some guys like to do everything at once, and that's fine. I don't like that. It's not because it's messy, or it probably is quicker to do them all at the same time, but I like to watch the flow of things. And so as you see me place this in the mesial buccal canal, squirted the sealer, and as I kind of push in, you'll see sealer come up the mesial lingual canal. Okay, so I know I got some fluid coming through. But let's just pretend I do have an isthmus that was opened up, for instance. And how did I really wick out the fluid, albeit it's water? But how did I wick that out? And the answer is you don't know unless you push from one side into the other. And so what I like to do is then wick it out with another paper point. And that's what you just observed me do on the mesiolingual canal. And then I'll just reapply more sealer and then just do a glorified or a modified continuous wave. And at this point, I'm just searing it off and down packing it and trying to push that sealer around. And that's about the extent of it at this point. So hopefully by what we just observed, I've opened up an isthmus, but I don't know that yet. I'm just hoping for it. And hoping that I did a better job than the previous guy, and that we found the causative agent and cleaned it up for the patient's benefit. All right, so now we're on to the distal. You know, the distal's pretty big. If you remember, I had a 35 go in there with gutta percha. My terminus didn't change, so I kept the same cone. So it's not like I'm getting a lot of friction lock along the long axis or in the middle third or the coronal third of that canal. It's just binding passively, really, at the apex from a trim standpoint. And now I'm just going to try to sear it off. And because I knew that, I didn't want to push anything out either. So I'm being a little bit ginger with it. And sometimes when that happens, you can pull your cones if you didn't really sear it out like that. So now I got to go put a new cone in. So when that happens, I got a choice. Do I go try to refit, re-x-ray, you know, all those steps that we had, and remake the new cone, because this was a trimmed cone. What I did have going for me is these are calibrated cones. And so I knew visually where my marks were on the cavo surface margin. And so what I just did is I said, well, I didn't really trim it that much. So I grabbed a 40, and then I placed the 40 in, and it matched to my corrected length, if you will. So I always pay attention to that. That's why I like calibrated cones. And so what that allowed me to do is to make those certain assumptions and then go right back to keep my flow going and keep time down. But those would be my decision trees that you have as a doctor, and I have as a doctor. Being a doctor, that's what I have to do. So in this, for instance, I used length to kind of solve that pull when I pulled that cone out, and then just put in a bigger cone. It matched up. I'm confident with it, and I went forward with it. That was the decision I made. And so now I'm just down packing the top. And you know, it gets a little bit messy at times like this. Like you can see sealer and gutta percha. And so if we're not doing, well, even if we are doing a restoration, I like to clean that up at the end. I think we're oftentimes judged by what the presence is when another doctor goes in. Like if your referring doctor is doing the filling, I like to really clean this up. Not leave gutta percha smeared under somewhere or under a pulp horn or sealer somewhere, which affects his bond, that kind of thing. And so I'll clean this up, and I'll even scrub it clean with a conditioning agent or alcohol or whatever it takes when I'm punting this back to my referring doctor. But when I'm not, then I'm going to have the same protocol because I have the same dilemma my referring doctor does. I don't want to seal in that mess. So I'm going to bring this up to the pulpal floor for convenience of bonding. Tamp that down a bit, and then do my cleanup. But again, you know, in thoughts of using the GentleWave and knowing what it can do when you have defective dental materials, such as defective sealer set under a crown because it's worn out, or composite walls, whatever, I'll be able to sort of make clinical decisions along the way on what I report back to my dentist. But then when it goes well, I'm actually really confident that what's there is good to go. And that's where I am here. And again, I keep saying this, but man, I'm not the first time into the same crown. This is at least the second time into the same crown. Well, I know for sure it's the second time into the same crown. So now I'm gonna just clean up. I clean up the occlusal table. I'm just using alcohol right now and a bendy brush. We're 44 minutes into this. And then sometimes, you know, my assistant will give me a few of them until I feel like I get things kind of clean with the alcohol. And then look around here. And then we'll blow this dry. All right. Okay, so went through my conditioning. You know, there's a lot of bonding agents out there, and you'll have to make the decision on what bonding agent you like. I actually favor a two-step bonding agent, candidly, because I want to do the work of removing any of the products that may be in there from our root canal procedures. And with a single step, I mean, you can rely on alcohol, but I like the conditioning agent because I feel like I can scrub the pores of the access a little bit better. It just makes me feel good. And so I'll use that bonding technique instead of a single step bonding technique for that reason. And then it also gives me a chance to actually scrub the top of the crown with it as well. And I'm using a comprimer in this, for instance, along the pulpal floor. And just kind of drawing along the floor to minimize any voids or air pockets that can come in. These dental materials are never perfect, and it bothers me that they can inject bubbles just by the way it comes through the delivery system. And so when that happens is you keep drawing it, you can draw out that bubble in the comprimer in this case. A lot of guys like composite. You can use a glass ionomer. I'll do this commonly where I'll put it on the floor, I'll set it, and then I'll just layer it up, although it is dual cure. And the shrinkage on this product, the C factor on this is supposed to be ideal for this, per the manufacturer. And then I'll just kind of play with the access. I don't, you know, I like working with the material when it's partially set, so I'm not, as I'm smoothing up against the walls, I'm not creating divots. I'm trying to minimize that. So I'm not in a rush here. I'll let time, the chemical cure of itself, work to my advantage as I try to smear and close all the walls of my access. That way, when I'm coming back to do a modification, hopefully it's minimal. At least in my mind, that's what I'm shooting for. Some guys overbuild and prep down. but that's my preference. So I don't feel like I need to polish things up as from the grit of my diamond. And then we'll do our final light cure here. And again, that same technique with Sound Seal. If it sweats on you, you'll see that kind of sweating look through it. You can cure it again. Touch it with your glove to see if it's sticky. And then just take off the flashing. I like finer grit diamonds at this point. And if I got any, as I was pulling the comprimer over the occlusal table, we'll just kind of flick that off with this burr, and then create your anatomy in there. You can write your initials in the composite. Patients don't care if you do that. You just sign it. Just kidding. Thought you can say this was done by me. Put a big old F for Facer in it. Kind of sounds funny, but I have had that request before. But use a flame if you do that to describe it. All right, so let's take this rubber dam off. One of the things that we didn't see in this case was the level of anesthesia. I like my anesthetic anesthesia technique. You'll notice that I have an X-tip if you look in the patient's mouth right in that third molar region. I did use an X-tip. There was some difficulty getting this patient numb at the beginning. And I will, if I leave an X-tip in, it's a little bit stubborn to get it out at the end, but you can do that. But I leave it in on occasions when you worry about any issues with anesthetic, because it's easy to actually give it back with the rubber dam in place. And so you never have to try to do anything different or poke the patient again. You can just use that same cannula again. And so I like that technique if I'm worried or if I have a very sensitive patient and any level of sensation will freak the patient out. I'll leave it in that case. I don't find that I do it very often, however. It's just there. But if you do that, make sure you take it out. Sometimes if you go back and look at my working length, at least you can see the cannula on the 2D x-ray, the working length x-ray. But if you can't see that or the assistant doesn't capture that on the x-ray, you could forget it and send a patient home with that cannula. And patients will think they grew another tooth back there, and it's not, it's your port. So don't do that. Have a protocol. Okay, so when I do the occlusion, I will actually have the patient bite and squeeze, and really I will put my fingers here and I will make sure they fire. They're numb. And when they're numb, I'm gonna pause this for a second. When they're numb, sometimes they'll just touch and they don't perceive that it's high. So I will let them clench and then make sure that they're in full set occlusion. But look at that outcome. So kind of start talking through the magic of the show, and that is, look what the GentleWave did to that mesial root. That was my causative root, right? That's where I knew the bacteria resided inside. And you can see on that, that there, really wasn't an isthmus up here. And I saw that the whole way through. It made me nervous. I talked about it. It really kind of, man, I want to see more than that. But you look at these finer details, and the only way this could happen is through fluid. And the only way fluid could get there is if you really removed any obstructions, which is why I was so picky with using the C-form and the alcohol and really trying to expose that. Because theoretically, if you just packed more schmutz in there in your retreatment technique, the GentleWave can't get in there either, because it's not going to remove that gutta percha. And so we remove it as a doctor. And so I love that, because my due diligence, I believe, was part of the reason why that was able to open up. And then I empowered the GentleWave, and that's fantastic, because look at that thing. And I do believe it matters, because I have a lesion down here. And then when I get into the apical third, I mean, it's arguable that there may be isthmus up that whole the apical third. And I can see some, dent in here and here, but for the most part, that communicates all the way up. And then voila, there you go. That's my justification and rationale why the GentleWave needs to be done on retreatments. And you see some sealer extrusion. With bioceramics, you hope that it goes away. But it's something that we follow and we like, and I believe this is an upgraded root canal in a retreatment scenario. In a lot of scenarios, they believe that. Like I said, good protocols. I've noticed that, I mean, we all have noticed that we're not 100%, and hopefully we are near to perfect, but sometimes we need a little extra, and I think this is the little extra we need to give our patients a very, very good outcome. And again, look at the seal of the crown. It's well adapted and intact and set. So there you go. Hopefully there were some pearls of wisdom. Go get some food. If you've watched this whole thing, you got to be hungry by now. And thank you. And by the way, if you subscribe, you'll get notifications. We're going to be doing a lot more than this. And ring the bell so you know how to get those notifications. They'll follow you. And thank you so much for watching. And who was the patient? Who was the doc that asked?
Sean Roberts.
Sean Roberts, thank you for asking a question.
Nice result. Thanks for doing this.
You're welcome. And by the way, even though after this event, if there's more questions, just we check them and we'll respond. We had a question come by last week. What was the question? They were asking about something.
Oh man, I don't remember.
Anyways, can't remember what they asked, but we will answer the question if there's anything comes up. So Godspeed. We'll see you later.